Our second presenter for today's session is Sandra Turley from Far West Local Health District, who'll be presenting on Cancer Care Referral Pathways, a rural perspective. Please welcome Sandra Turley.
Thank you for letting me speak here today. I'm going to talk about our Cancer Care Referral Pathway, a rural model. Firstly, I would like to acknowledge our team members. Melissa Cumming, Director of Cancer and Palliative Care Services for Rural and Remote Far West Local Health District, and previous members of the team, Jennifer Carter and Ruby Hook, both of who were psycho-oncology counsellors in the role at Broken Hill. Now, just a little bit of background to why we're here today about our local oncology services. The Broken Hill Oncology Service was established in 1998. These services consist of monthly face-to-face visits from our medical oncologist at the Royal Adelaide Hospital. We at Broken Hill have an oncology day unit providing the community with a 5-day-a-week service for the delivery of chemotherapy and support transfusions. In 2006, the introduction of the Cancer Care Coordinator role and the psycho-oncology roles enhanced our cancer services. In November 2008, after 10 years of service provision, the Royal Adelaide Hospital lost capacity to provide us with an oncologist. And as you can imagine, this had a profound impact on our local cancer services, existing patients, and also patients that were newly diagnosed. Because we had no oncologist, our patients were being referred directly to the metropolitan treatment centres by their GPs, and local cancer services were being bypassed, and patients had no access to care coordination. This put us in a very difficult position because we didn't know, local cancer services didn't know how many patients were being transferred, we didn't know who to follow up after their diagnosis, and the patients themselves had no support. We found that care became very fragmented. There was increased crisis presentations to the emergency department for patients returning from our metropolitan treatment centres. There was increased anxiety in patients and carers. And this anxiety was fuelled because of the lack of communication between treating centres and local healthcare providers and the lack of support upon their return. On a few occasions, patients returned from Adelaide on oral chemotherapy and were not appropriately supervised. These patients continually took their medications without the required break between cycles and ended up in neutropenic sepsis requiring prolonged admission to the local hospital. On questioning the GPs, they reported having no follow-up with the patient and no correspondence from the treating specialist. This is an ongoing problem, poor communication. This lack of coordinated care and the lack of information for patients frustrated emergency doctors, fuelled anxiety in patients and carers, and also fuelled the anxiety of me in the Cancer Care Coordinator role. Patients were simply lost in our system. So what did we do? How could we improve care, patient care and coordination? There was much discussion around this. What we needed to do was to get our local cancer services back on track. We needed to engage with the GPs and encourage them to refer patients to the Cancer Care Coordinator as a first point of contact following a cancer diagnosis. We actually wanted our patients to walk out of our GP surgery with a plan in place. We wanted the patients to feel supported and receive coordinated care. We wanted to improve communication between local and metro service providers, and we wanted people to access local cancer services again so that we could collect valuable information to help us regain our face-to-face visiting medical oncologist. and we wanted to work with the GPs to develop a cancer care referral that worked for them, the patients, and local cancer services. Our first step was to open discussions with the GPs highlighting the problems that their patients were experiencing. In 2009, we applied for an innovation scholarship through NAMO and used this funding to commence stage 1 of the Cancer Care Referral Pathway. Stage 1 began in May 2010 when we employed a consultant with a background knowledge of cancer and palliative care to conduct literature search around interviews with GPs, practice nurses, local cancer support groups, and health advisory board members, looking at the barriers to referrals and what community members actually knew about their local cancer services. The findings of these interviews were presented in a comprehensive report. There were 9 findings in total, but the most significant being that the loss of the oncologist naturally had a profound impact on our service. What we also found interesting, despite numerous interactions with GPs and the communities, that nobody really understood the role of the cancer care coordinator or even how to access the coordinator. There was a lack of general awareness. There was a lack of awareness about general supports available in Broken Hill, and it also highlighted that we had a transient nature of GP workforce, with most GPs at that time just staying in town for around 12 months to 2 years. So how could we expect them to know what was available locally? The information from the scoping study clearly identified the need to promote the role of the cancer care coordinator within the community and to proceed with the introduction of the Cancer Care Referral Pathway. And in 2011, we applied for further funding to progress that, but we were unsuccessful in that. So then we had to just wait around until we could find some more funding, and in 2012 we were successful in our application to the Cancer Institute, and that enabled us to develop our pathway. Developing the pathway was done in collaboration with the GPs. It wasn't just a one-way process. We had a lot of interviews, a lot of interaction with the GPs, because we wanted to develop something that was functional for both the GPs and local cancer services. The pathway had to be simple, easy to use, time effective and cost effective or cost neutral to surgeries. So we had interviews with the IT professionals from the GP practices, and we used existing forms and referral templates that the GPs were familiar with. We uploaded Section B of the IPTAS forms for existing pathology, radiology forms, as well as external provider forms into one electronic folder. We also provided a hard copy of this pathway and a referral criteria for the cancer care coordinator. So why would the doctors want to refer to the cancer care coordinator? Simple, to get easy coordinated care for their patients. Everything they needed was in one folder on their computer. One click of the button took them to their folder, and they could fill out their existing referrals and then just pass them on to the cancer care coordinator. We developed promotional material to inform staff and patients about the pathway. We developed brochures, magnets, business cards and flyers, and we also produced a TV commercial which ran over 15 TV channels for a period of 18 months, advertising that there was a cancer care coordinator in Broken Hill and how they could access them. On your screen, you're just looking at the referral criteria. We laminated that criteria and put it in all GP surgeries. We put that in consult rooms within our local hospital just to give the doctors a nudge. That's just a copy of our brochure, and the purple paper there is the criteria for referral. We saturated the market with our promotional material, placing flyers around the local pharmacies, GP surgeries and the hospital. We attended local support groups, had interviews with local radio stations informing the public about the pathway and identifying the cancer care coordinator as a point of contact following a diagnosis of cancer. The Cancer Care Coordinator provided the GPs with acknowledgement of referral letters after initial consultation with the patient, and that was to keep them engaged and to improve the communication. Copy of all reports and follow-ups received by the coordinator were also forwarded to the GP. The public launch of the pathway and the release of the TV commercial finally took place 4 years after the planning, and we did the launch on the 4th of July 2013. Can we please play the video now? It's a very short video, so...
Do you have a recent diagnosis of cancer and don't know where to go for help? The Broken Hill Health Service has a Cancer Care Coordinator to assist patients and carers with treatment information, travel, accommodation and support. The Cancer Care Coordinator is available to see patients in the private or public sector.
As you can see, very brief, but when you play it like 50 times a day, you certainly saturate the market, and I even said to my husband, oh God. And it has been really effective. We've got people, coming up to me in the street and saying, see you on telly. Yes, see you on telly. If I could get paid for that, I would be a millionaire. So the launch was very successful, and it was attended by all sectors targeted in the pathway. We had community members, we had specialists visiting our hospital, we had the flying doctors, we had GP representation, we had hospital hierarchy, we had surgeons, we had nurses attend the launch, and it was really good, it was great. So remembering the aim of the pathway was to achieve recognition of the Cancer Care Coordinator, to promote that Cancer Care Coordinator as the first point of contact after a cancer diagnosis, to promote the local cancer services. We wanted to ensure integrated care coordination and raise community awareness of the role. I think we did that. I'll take my glasses off because I can't see. So this is our stats prior to the pathway. And as you'll see by these numbers, the 12 months prior to the pathway, which was dated the 1st of July 2012 to the 30th of June 2013, I had 7 sources of referrals to the coordination service and a total number of 43 referrals, and that was in a 12-month period. Post-introduction of the pathway, dated the 1st of July 2013 to the 30th of June 2014, our referrals went up. We had 19 sources of referrals and 148 new cancer patients referred directly at point of contact, at point of diagnosis. So there's been a significant number of referrals since the launch. We still have a ways to go. Awareness, we're still out there, we're still saturating the market. Patients are not falling through the gaps as they did before. Care is coordinated and it's in a timely manner. It's integrated. There's great improvement in communication from metropolitan to local service providers. Patients feel supported in navigating the system. Testimonial from one of our patients who is no longer with us. The Cancer Care Coordinator has given me a lot more confidence about the process. My feeling of being back in control of my body, explaining the recent scan results in terms I can understand, and helped me to overcome problems with pain, medication and side effects. Is our model sustainable? Yes, it is, because it's embedded into all the GP practices in town. There's ongoing collaboration and education. We now have provision to backfill the position of the Cancer Care Coordinator when she's on leave. Our advertising material and resources continue. There is ownership of coordinated care. We work closely now with our Marama Health Service, our Aboriginal health care providers. I'm currently undertaking formal evaluation of the project through a research project. We have formed new collaborative partnerships between all sectors. Is it transferable? It is transferable. Parts of it are transferable across small, rural communities. Promotion of the role is, paramount to its success. You can't just set it up and leave it go. You actually have to keep push. And particularly in our town where we have a lot of new GPs coming and going, we have to engage in those, so it is ongoing. And parts of the advertising and electronic pathways are transferable to larger settings. Thank you for the opportunity of letting me speak today.